morning, everyone. I'm going to start today's EGM Conference. Today, I'm going to start the EGM Conference with the treadmill test. So this is the result of the treadmill test during the recovery phase. And for today, we have a special guest. So that's it.
Nothing is a special guest. He will attend in routine.
Hello, I'm Kang Nam, and I'm the third year resident in St. Peter, and I will be in fellowship on June 1st. So let's meet you. Thank you.
Yeah, he asked you to read this ECG.
Read it.
Not even This is treatment, right?
Yeah, treadmill test, and during the recovery phase, about 1 or 2 minutes start from the recovery.
Very unusual ECG. Okay, Dr. Nam.
Yeah.
We have a simple rule. If the assigned fellows or somebody didn't keep silence 5 seconds, we will move to next people. Okay?
I go first because first one is easiest. I see the clear delta wave here and short PR, so there might be a pre-excitation accessory pathway.
You mean the people narrow cross,
Yeah,
relatively narrow cross, right?
yes. So and when you see the V1 lead, the delta wave axis is negative, so maybe it's coming from the right ventricle. And the three-quarter lead shows more QRS complexes, so I think there is more than one accessory pathway, I guess. But so far, I think this is very complex EKG, so maybe next person describes interpret more.
So anyway, then Dr. Kim make decision. This patient underlying rhythm may have a pre-excitation, right?
Yes.
Okay, who's next? Okay,
Yes,
Dr. Yoon.
Yes. Can I take mouse? Microphone.
That is not a mouse, that is speaker.
Okay. Okay. There's a sinus rhythm. Heartbeat is around above 150. So initially, this beat looks like a big mini PVC, but here is a short PR interval, and that's the way it's seen. And of course, after this, XVT started. Narrow care complex tachycardia occurred. So then EVR leads this segment in the way to 2 millimeter, and also V1 leads V1 R wave less than S wave. It's a region coming from the right side, and also lead to 2 delta wave. Delta wave move that you can see. So, and my brief summary is excitation syndrome and coming from right side. That's it.
Okay, you also mentioned about fixation, but nobody
But
tells about the wide chorus, the bigeminal rhythm. Dr. Chen?
Also great. This is the PVC by and the short PR with the excitation recovery.
Bit louder. I always ask you to speak louder with confidence.
There is 10 to 10 joules around between with 2 and 3, and the QRS topology, there's maybe 2 kinds. This is different from the others. Maybe this thing underlying delta wave measure appears the accelerate pathway, and it's maybe without causal.
Okay. So I have 2 questions for you. Number 1, next copy, right? So how do you determine those the bigeminal rhythm and the wide currents complex followed by delta wave? Okay, what is that? Next, the question number 2. If you lead precordial lead, probably first 2 bits looks like a pre-excitation, but all of a sudden it's faster and trigger even narrow QRS tachycardia. So what is the mechanism of induction? Too difficult question.
So the first is about the bigeminal rhythm. Looking at the morphology, it could be an APC with aberrant conduction or a PVC.
Selection deleted. CO.
However, when you look at the polarity, especially in the inferior leads, you realize that it's completely different from the sinus rhythm. So
Mouse. It was a mouse.
in the sinus rhythm, we see that we have an inferior axis in 2, 3, and AVF, but this bigeminal or this ectopic beat has a superior axis, which suggests that it's coming from below in the ventricle upward. So even though the intrinsic deflection is quite sharp, I think these are PVCs, short coupled PVCs. So that's for the first question. Then over here, we have 2 of the ectopic beats, which then lead to a narrow complex tachycardia. This suggests that these ectopic beats are conducted retrogradely into the atrium and then start a re-entry tachycardia going retrogradely up an accessory pathway and then down the normal conduction system. That is why the QRS complexes are narrow.
So your interpretation is first bigeminal rhythm is APC with augmented delta. Am I right?
No, so I think this is PVC.
PVC.
Yes, because the polarity is completely different from the
Okay.
sinus rhythm.
Then why there's a short couple the 2 wide QRS, then started narrow QRS.
Yes.
Is that a APC?
No, so
Also
the
PVC?
also PVC by Gemini,
Also PVC.
and then it's conducted up into the atrium and then starts
Okay,
a circuit.
it's more and more interesting. Okay, let's please debate. Question.
So let's look at lead 1 or AVL. If we look closely at lead 1, this is the sinus beat, and we can clearly see a delta wave in the sinus beat.
Mhm.
What I feel is happening is like an atrial stimulation protocol is happening. An APC comes, which gets blocked in the node and completely transmits over the pathway, accessory pathway, giving rise to an accentuated delta, a complete pre-excitation. And this is happening after each sinus beat. There's an APC with which conducts completely over the pathway, because it's coming very at a short coupling interval after the sinus rhythm when the node is still recovering from the refractory period. So what we see at here is that S1, it's like an atrial extra stimulation protocol. S1 blocks in the node but goes over the accessory pathway. And sinus beat and atrial extra blocks in the node and goes over the extra pathway. Here it's like two extras coming, which completely transmit over the accessory pathway and initiate here it initiates a narrow orthodromic reentrant tachycardia, which where the accessory path now the next APC finds node conducting for able to conduct antegrately and then goes up the accessory pathway and initiates a narrow complex orthodromic reentrant tachycardia.
Okay, so you believe it is a frequent APC induced tachycardia?
Induced ORD, where the accessory
Or also tachycardia. Then, okay, theoretically, I agree, but how can you prove is this the wide cursor bigeminal rhythm is APC based on the ECG? Theoretically, it's acceptable, but what did you see in the ECG?
this
What about the ABF?
AVR.
ABF bottom, lower.
There's a P wave before the
Yeah, next bit.
again P
Yeah,
wave.
T wave. Yeah.
P wave before this.
T wave morphology is a little different, right? And depending on coupling interval, so the ABF QRS wide QRS morphology changes. Okay. And I bet B6 two wide QRS rhythm may be also aberration or augmented pre-excitation. Okay, so who can interpret other ways in other ways? Dr. Huang, Dr. Om, you can say, okay. It's really interesting ECG.
Yeah, I agree with Martin's.
You shifted to APC.
Delta augmentation.
That's all.
BC probably.
Okay, you advocate copy. Why?
BC morphology is a little bit different. So this ECG was taken when the patient is standing or running.
Yeah, after treatment.
Anyway, yeah, standing. So it may noise can be interrupted. So that's why the PVC morphology a little bit the last one can be different. So the patient is standing. Patient was standing.
Yeah. I'm not sure of the recovery pace, but
Recovery patient is standing.
Still standing.
First
So
of all,
one
standing.
the recovery 1 minute and only 2 minutes.
yeah, 2 minutes.
Okay, let's vote.
Before you vote, Dr. Pop,
I want to add one thing that
Dr. Pop, can you hear me?
Hi, Dr. Wang.
How are you?
Good morning.
Good morning.
Yeah. Everybody is fine. So how are you?
Okay, good. I'm doing okay. So
I
question.
said you left to United States.
Yes, I'm in the United States right now, my home. Maybe there's some delay of when I talk, but you gotta bear with me. My internet connection is probably slow. So,
But it is clear. Your voice is clear.
okay, good. So clearly patient at the pre-excitation is a sinus rhythm with a minimum pre-excitation ECG. But this wider complex they're discussing, if this was a pathway, where would be this pathway? Somebody can point to where the pathway location is?
Whose turn? Dr. Nam, your turn. We circulate one round. I think it is not easy for third year residents.
Okay. So just limbless standpoint view, 1 to AVF, it's clearly suggestive of a postal septal.
Yeah.
But also could it be crux PVC as well, exact same morphology.
Mhm.
Because you have lead 1 AVL is markedly positive, and then you got a slight R wave in the lead 2, and then you got the lead 3 QS pattern, and then AVF is a QS. So you have to wonder, is this a PVC or this is the delta wave? My question to you, why the delta wave would have a double notching in the lead 2? You see there's a 2 RSR pattern.
Follow.
Have you seen lead 2? Look at the lead 2, QRS complex. Yeah, that PVC. Oh, it's delta wave or pre-excitation, whatever you might call. Why the delta wave would have such a pronounced notching? Is that possible delta wave have such a RSL pattern? Anyone can answer? And similarly, you have a notching in AVR as well. You can see AVR. Yeah, downstream notching there. Okay, all the way up to the QRS complex. That clearly, after the whatever the pre-excitation conduction time, beyond that. So those findings are perhaps suggest something. Now, on the rhythm strip, V1, as someone pointed out already, there's an independent atrial activity going on, looks like, for the first couple of bits there. So you can see it clearly better on the in the lead 1 or B1. Somebody points out pre-narrow QRS complex small notching, but before that, second complex QRS complex wide complex lap bundle morphology pattern, but end of QRS there's a double notching there. I think that suggests atrial activity there. Yeah, that guy right there just passed. Okay, so there's a maybe retrograde P. And the other one is a sinus. We can tell, sure. But if you look at also in the V6, after the narrow complex, there's another notching coming through, that one. So how do we explain all this? Which can be seen V5 and V4 as well. You can see, follow that V5, go up to the V5 and V4. You have clearly, there's an independent activity going on. Now you can see also in the V1. Okay? It seems to me it's the same P wave, the first one you had. So you have to explain all this before we vote, I guess. And then other thing that really matters a little bit for me, if you look at the very first QRS complex, you follow that rhythm street, keep going to the left, keep going to the right, V2. Go to the V2. Yeah, you see the QRS keep getting sort of a smaller amplitude, and then grows up again, so on. And then you can see in the V1, QRS width also vary time to time, especially in V1. If you look at it, V1, look at the QRS complex, narrow complex. Yeah, keep changing. It's not just amplitude, also change the duration. So you have to discuss all that before you make a vote. Unless you got to change your mind or you don't change your mind, and let me know what you think.
Okay, Dr. Wang, watch him
Yes.
raise his hand, please.
I want to point out two things. Whether this is an APC or a VPC depends whether we believe there's a seeding P wave before these wide complexes. And as Dr. Park pointed out, there's a notch in the P wave in AVF before the wide complex. So if you believe that this is a APC, then this to me is nothing but an augmented pre-excitation. Regarding
Yes.
the first 3 beats in the recorder leads, what I believe is that the first 2 beats conducted entirely over the pathway. The next APC conducted over the sinus node integrately over the AV node and gave rise to a narrow complex and returned this notch in the T wave of the third QRS complex, which is very clearly seen in V4, V5, and V6. It's the retrograde P wave going up to the pathway and then finding the AV node again and initiating an ORT. That's how it's.
So,
and the QRS, this is the QRS alternance, which is often a feature of AVRT. the alternate this varying QRS amplitude because that's the feature of AVRT.
Anything else to comment about the precordial, the amplitude change?
So what's the rate of tachycardia you're looking at here? Very fast.
Very
Very
fast.
fast.
Yeah.
Yes. So you still believe that's an orthodromic tachycardia?
Potentially. But the regarding the precordial, the amplitude change is because it is treadmill exercise immediately after exercise. So probably the patient
Catecholamine.
felt,
Yes. Mhm.
felt some shortness of breath. And the
Right.
V2 and 3 is most sensitive lead depending on the chest wall movement.
Mhm.
Maybe breathing.
Okay. So you believe that there's some artifact going on, you think then?
I believe so.
Okay. So then now you guys can vote and let's see whoever what you think this is a APC, bigeminal APC with the pre-excitation, or this is orthodromic AVRT after the couplet of PVC. How many of you agree this is VT or SBT? Now you guys can vote.
Okay, wait then. APC SVT 3 and PVC and 8 or whatever.
PVC, SPT.
PVC 1, 2, 3. Oh, PVC 5. APC 3.
Okay.
Then other people did not answer.
Oh. So what is the feature that this is a delta wave? Do we know?
Yeah.
If this is a pre-excited,
Yeah.
do you think that the intrinsic activation time is this fast? Especially you pre-excited pretty widely?
Dr. Chong will show other slides.
Okay, let's take a
Yeah.
look.
Okay, I will give some additional information.
Yeah, please.
I will go back
Yes.
and this is the similar wide QRS complex in the bigemini pattern.
Mm-hmm.
And this is my one additional information. I
Uh-huh.
will give you a little time.
Did you measure the whether there is compensated pulse or not?
Yeah, I measured it. I think it is compensatory, the interval.
Compensated pulse.
Yeah.
Okay.
And I will
That's important message.
So this is the ECG what we are looking about, and take a close look at the interval of the cycle length, and this is succeeding the tachycardia.
Okay, stop that right there. You got looks like an alternance there.
Yeah.
QRS.
That's definite alternance.
So how do you explain this with APC or PVC, whatever you guys talking? It's a very interesting ECG, actually. So what do you see here?
RR is also alternate.
And so here there's the QRS alternance, and then the RR intervals are also sort of paired, like a kind of group beating of some sort.
CA.
Like some kind of group beating.
Oh, what do you say?
Who is the she?
So I think this tachycardia is going down the AV node, and because of how fast it is, there's a bit of a prolongation, like the Wenke back kind of phenomenon. That is what accounts for the slight increase in RR interval over time, because you have the first complex coming, and then the second one is so short after that, and probably the AV node prolongs the next one a little bit, which might account for the differences in the RR interval. The QRS alternance is a feature of very fast tachycardias, as in AVNRT or AVRT. Yeah, so I still think this would be an orthodromic.
But how will you explain that there is a coupling interval change? If it is the rapid tachycardia and QRS alternance, mostly the R interval should be same, constant, but it is coupling two beats. I
So,
always catch you challenging questions.
question you have to answer with the RP interval or PR interval changing. What is changing? Look at the V1 before you answer the question. What is changing?
RP.
RP or PR?
Jose.
Measure carefully.
Yeah.
V1, lead the V1, you can see better. V1,
PR.
there's there, notching to the QRS. Next notching is longer to the QRS, right?
It's very interesting.
Can you think about maybe this is a fast flow conduction, AV node? Is possible? Patient has a two AV nodal physiology. Orthodromic tachycardia going one to the fast, the other one going to the slow.
Yeah, it could be, but it depends on how's the PP interval. Is it regular or bigeminal PP?
You have to measure. I think you can measure. That's what we're asking. Difference of diagnosis here. Whether you have a
Measure, please.
Mhm.
Where is your caliper? You didn't. You didn't come without your weapon.
Because Dr. Park, you
Yes,
have
sir.
to measure RP interval because
Yeah.
retrograde is the same.
Yeah.
Only the antidromic is different. Okay.
Yeah.
Therefore, PP can change. But the question is that that's why I said RP and PR interval you have to measure, and it looks like you have a same RP, but a PR change every other beat. Okay.
So even though I cannot see the P wave clearly, but it
It's a
could
possibility.
be the APC bigemini or the bigeminal echo beats generate this kind of couple group beating. And another thing is because the heart rate is very fast, but the delta is minimized, so I don't think this patient dies suddenly.
Well,
At
that's
least.
not as clear.
Yeah.
But the question is that what's the mechanism about this tachycardia that I think is most interesting? Okay.
I bet it is the bigeminal echo beat.
Bigeminal echo beat. Okay. So that's what you think. Oh, could it be? Are we discussing fast, slow AV alternating conduction? Let's take a look at it. Okay. So
this I will show you to the end of the tachycardia. It keeps moving on the alternance pattern, and this is the how this tachycardia ends.
Okay.
So I will move on to her history now.
Oh, okay.
And so this was her history. This was the EKG we saw earlier, and this was her baseline EKG.
Okay.
So we can see the delta wave in here, and she was a 56-year-old male, and she has a tachycardia more than about 10 years, and it is once in months, and sudden onset and upset, lasting for about 2 minutes. She didn't have any relevant medical history. She has a normal range of BMI, and this is her chest X-ray, and this is the her echocardiography report. And was I open the electrophysiology study results? No. So
No. Briefly.
Yeah. So the next slide is my last slide.
Okay.
So
show us.
So we did the ablation yesterday. There was a manifest bypass tract at the left and right photoreceptor area. So we did ablation for the both left and right lateral pathway.
Why
Yeah.
not drop?
What do you mean?
I think,
Receptor.
yeah, lateral is wrong. Left and right external
Yeah,
pathway.
she has the right post-receptor accessory pathway. So can you go back to the first ECG?
Okay.
In the outpatient clinic, no, next one. Next one. Yeah. In the outpatient clinic, after watching this ECG, I was scared because it looks like PVC, almost RNT. Yeah, but after can you show me the first one? Yeah, this sinus ECG, wide QRS delta wave, the polarity is almost same to the previous one. So I guess it might be the APC by Gemini. So I scheduled elective ablation, not emergency. I did not send the patient to emergency.
So why are you saying that the patient has no risk of sudden death?
Because it is APC.
I know the APC, but the tachycardia rate is very fast. You know, the postural subtaxillary pathways notoriously found to be associated with high risk of sudden death. Because
but the reason why I prescribe exercise treadmill testing every patient with WPW syndrome, even though it is not the class 1 indication for diagnosis of WPW syndrome, if the QRS, the delta is augmented during exercise, probably this patient is a higher chance of sudden cardiac death. But this patient rather narrow QRS, so I don't think this patient has high risk of sudden death.
So I think that, prediction of a treadmill based on the risk of a sudden death in postural subtle pathway notoriously shown to be wrong, many patients. Because if you find retrospectively people presented the VF arrest in WPW, most of them are postural subtle, especially patients like this have a multiple fiber. So you had ablated both sides, right, left postural septum to eliminate tachycardia.
Actually, the successfully ablated from right post-rectal by single burn. But I delivered the insurance burn to the left post septum.
So, we had a case not too long ago from Samsung Gimin Center. Patient presented the postural septal pathway. He had a 2 insertion. It was very interesting because he also had very fast tachycardia. We ablated left side. Well, he was minimally pre-excited until we ablate the left insertion. And then suddenly became wide complex pre-excitation and the manifest from the coronary sinus os. So we ablated both sides and eliminated tachycardia. So it's not uncommon. People have a multiple fiber orientation insertion on the postural subtal. That has the mechanism of BF arrest, particularly in atrial fibrillation. So I think John Gallagher shows the early days. If you really want to know whether you have a sudden death risk, he induces atrial fibrillation in the lab to see what is the shortest RR interval you get. If you get an RR interval shorter than 240 milliseconds, he believed that in his paper, high risk of sudden death, independent of a treadmill testing business. Okay, that is what we know. So I don't know whether this patient has, but so you believe patient has pre-excitation with a PAC, right? That's your belief? If that's the case, how if that PAC could cause atrial fibrillation eventually in this patient if you did not ablate it? Certainly yes, because it's such a very close coupling. Yes. So then your risk assessment may be wrong. I think we should think about seriously in the lab if you want to assess that induce AFib. Okay.
But the high risk of sudden death in septal bypass rate is anatomy dependent analysis, but I mean the electrophysiologically, if the heart rate is over 260 milliseconds, shorter than 260 milliseconds, but no delta pre-excitation, probably that patient has low risk of sudden death.
That is a statistic crossing data, but I think I still, in practice, when we assess a posterior subfracture pathway, because pre-excitation index vary widely among these people, we probably induce the AFib. That's what I would recommend.
As you mentioned about the AH jump and
Mhm.
the PR jump, this patient
Mhm.
had the AH jump, right? Dual epineal physiology, as far as I remember.
Okay,
You don't remember?
very interesting case.
Yeah.
Wonderful. Yeah,
Thank you.
thank you for so interesting case.
I have a question.
Okay,
Yeah.
Dr. Om has question.
Does she have coronary artery disease? Because just after treadmill, STA depression.
We just did the treadmill test and we didn't evaluate her coronary anatomy except for the TMT. Yeah, so, and she didn't have any history of other disease.
I think that even after the successful ablations, some patients shows a T-wave inversion has to change because of a memory effect.
Yeah.
However, it doesn't recover for a few weeks, probably when it's the repeat treadmill exercise test. But this is young lady and no chest pain.
Right. That is actually, if you look at the paper by Michael Rosen, just adding the comment, cardiac memory, posterior septal, maybe somewhat has to do with the VF arrest in these people. Michael Rosen paper about cardiac memory, if you guys read about it, he mentioned briefly about this. So he's in his Columbia people, they experimentally give a ACE inhibitor, appears to reverse quicker. But no data shown this is a high risk for sudden death. Okay, posterior septal ablation patients.
Can
Hey,
you
thank
hear
you.
me?
Yes.
I have a question. Can you show the tachycardia initiation to have lead ECG?
Oh, this Dr. Kim Min?
Yeah, yes.
Hi, Dr. Kim.
Yeah. Hello. I wonder that the initiation of tachycardia lead V6 especially narrow QRS, and then we can see the PAC and delta augmentation, and next P wave is in behind the T wave, and then delta wave very slow. I think that the ventricular activation slightly was slowed. So in EPS, I have a question whether the accessory pathway has a decremental property or not in electrophysiology study.
No decremental property.
Yes, but ECG is very interesting, I think.
I think your comment, your question asking is similar to your patient. The degree index of a pre-excitation variation has to do with how many input you have. Remember your patient, we ablated one and became more excited?
Yes.
Similar to this. So people have a multiple HR input. One get blocked, the other one get conducted, if it's a wider complex compared to the other. So I think this is what you're showing to us. Okay.
Thank you.
All right. Thank you so much.
Thank you.
Let's go to the next.
Good morning. So I'm going to present the EGM for today. I'm conflicted here somewhat. And so this is a 56-year-old female who reported with episodes of sudden onset and offset palpitations. Each episode lasted about 2 minutes. Her echocardiogram and other clinical features were normal. So this was her ECG in the outpatients. We see here that there's a delta wave, negative in lead 2, which per the Aruda algorithm suggests a possible MCV location of the accessory pathway. And this is her ECG after the stress, her tachycardia after the stress ECG, which we've discussed. And this is her chest X-ray So she came into the EP lab for an EP study. On the left, we have the LAO view after catheter placement, and on the right, we have the RAO view. And at the beginning of the procedure, this was her resting ECG. We see that there is a little pre-excitation here in V1. However, the overall QRS morphology is different from her outpatient one. In the outpatient one, 2, 3 AVF were all negative. Here, leads 2 and AVF are more positive. But we still see that there's some delta. We still see a delta wave present. So this is the initial EGM at the beginning of the procedure. Cycle length of 725 milliseconds, AH interval 65, HB interval 33, and QRS duration 73 milliseconds. Looking at the initial EGM, when we look at H910, we see 2 things. First, we see the sharp atrial electrogram, and then a smaller fractionated potential. And then it appears that the V is earliest in the H910 electrode. For RV pacing, the earliest A, it's difficult to tell whether it's in HIS14 or H910. I think probably HIS14 is slightly earlier than HIS910. If it's HIS14 than CS910. But so CS910 being this, if that's the earliest, then that puts it around the CS OS area. But then I think the HIS910 is earlier. HIS14, sorry. This is the VA block cycle length on RV pacing at 280 milliseconds. And the VERP was observed during single ventricular extra stimulation test 600 to 60. RA pacing showed again the earliest V occurring in H910. And over here, we see that H910 again is the earliest V, but pacing at 260 from the atrium, we realize that the direction of activation of the ventricle changes. So over here, earliest V is CS910, but during RA pacing, earliest V is CS12, moving up, suggesting that the accessory pathway that was bringing the earliest V to CS910 was blocked, and therefore we had the regular conduction sequence. Echo beats were observed from during RA pacing 600, 250 to 220. So here we see S2, and then there's an echo beat. And then the atrial ERP was less than 600, 200. So tachycardia was induced by single extra 600, 300. And the cycle length was 270, AH interval 95, HV interval 26, and QRS duration of 74 milliseconds. And this was the surface ECG at the time of the tachycardia. And the tachycardia did not really sustain for so long. But here we see how it initiates and how it terminates as well. V reset was positive with a HIS refractory PVC. So in summary, a middle-aged female with sudden onset and offset of palpitations, the earliest V antegrade in sinus rhythm and with RAP was in CS910. Earliest retrograde A, however, was in HIS14, as we saw in the sinus rhythm EGM, there was what looked like a possible AP potential in the CS910. And after the block cycle length of what appeared to be the accessory pathway, there was a change in the V sequence. SVT was induced by PES and V reset was positive. So a diagnosis of the dromic AVRT was made with a right post-receptal accessory pathway. So the ablation catheter was positioned. Over here we see an LAO and RAO. It's just around the CS os area in the posterior septum, close to the CS os. So this is the pre-ablation signal, and this is where the ablation was turned on. And here we noticed again that H or CS910 has the earliest V, but as ablation goes on, when we get to this point, it changes. And now the CS12 has the earliest V, which suggests that the ablation successfully terminated the accessory pathway. And then post-ablation RV pacing showed VA dissociation. And then this is the post-ablation RA pacing. We can see that again the sequence of activation for the V has changed. So now CS12 is the earliest V within the CS leads rather than CS910 as before the procedure started. But because of the possibility of the accessory pathway having a single ventricular entry and then fanning out into the atrium with left and right components, we went ahead to do a transeptal puncture to ablate the left post-receptal area as well. So here we have the catheter position in the LAO view and in the RAO view. So this is the pre-ablation signal for the left side as well. And after the ablation, adenosine was given, which confirmed the AV block with no conduction across any accessory pathway. And this was the final EGM at the end of the procedure, and the 12-lead surface ECG after the procedure as well. Thank you.
Nice presentation. But I recommend to show the EGM of initiation tachycardia and termination tachycardia. Okay. And during ablation, you show the EGM of immediate before RF, but how long did it take to see change? Okay. Because all the audience has curiosity about that. Yeah. Okay, Dr. Wang, please comment the copy's presentation. What is it?
Thank you, so.
Still left? Okay. Okay, please comment regarding the copy's presentation. Dr. Next senior.
Just before ablation, delta wave is was not prominent. Did you map antegradally?
So even at the start of the procedure, the delta wave was minimal. There was very minimal pre-excitation, and this was the ECG at the start. Very minimal, and the QRS duration was narrow, 73. So I think that's why the pre-excitation didn't really stand out much. But over here we saw what looked like the accessory pathway potential.
I'm not sure that is pathway. That is just flip a signal of
Okay.
proteins, yeah. But when we see the ablation proceed, during ablation, the pathway will be separated.
Yeah, the pathway. Yeah.
Oh, Dr. Wang, come back, please.
Oh, sorry, my Zoom got dropped. So
Oh, sorry about that. Yeah, please.
no,
Matt.
it's my internet connection here. Now I missed some of the presentation. I apologize for that. Kofi,
Okay,
can
let's
you can you ask me something? Have you guys done CS venogram in this patient or no?
No, we didn't do a CS venogram.
Why you did not get a CS venogram? Any reason not to?
Because of overtime.
You should.
Sorry about that.
And so I think it's for the posterior subtaxillary pathway, it's important to know where the CS os. Can you go back to your tracing? You did the 8 extra stimulus there, very first one. Yeah. Let's see. Next one. Yeah, keep going. Keep A pacing. Okay. And then you have no, stop there. Go back there. Extra stimulus. Okay. Here, if you look at this tracing, what do you make out of this? AT? You got 3 bit of AT, right? After pacing. Or actually 4 almost, right?
Yes.
So you the extra stimulus, the induced state of tachycardia, 1, 2, 3, 4.
Yeah.
You agree? Yeah.
Agree.
And then after that, so that was pathway. I think is second APC did not conduct, third to conduct. Okay. Go to the next one. So your basically induction of a tachycardia here, you can see pretty much well, and the retrograde, the his as well as the your posterior subpole, pathway conduction, still eccentric, right? Little bit. So go back to the 2 previous slide. I think you were pacing something I saw in the his bundle area. Keep going. Okay, here. No, stop there for a second. No, you just go back to that A pacing. You had a narrow complex. Yeah, right here. What happened here? You think a pathway blocked during the A pacing?
Yes, because over here we have clearly
Right.
the V being earliest, but
Yes.
as we paced, the direction of the activation changed, suggesting that the accessory pathway that was conducting and causing the earliest beat to be in CS19 was blocked, and it was
I
following the
agree with you.
normal conduction.
Yes. But the pacing couplet with the your atrial conduction rate is exactly the same, right? Am I correct?
Sorry, can you say that again?
Your VA conduction, I mean the A pacing, antegrade conduction speed is exactly the same as the your conduction throughout the entire tracing, or they change a little bit. In other words, HV interval, do they change it? Do they don't change? There was some variation? No variation. That's what I'm asking you. So
No,
for
I
that
don't
one,
see variation.
you don't think so?
No.
Okay. Because of the first beat, if you look at it, appears to be slightly shorter, and next one is slightly longer. Then it looks like a settle down a little bit. So I wonder, first conducted bit, you capture extra stimulus, right? You're doing A extra, or you just burst pacing?
No, this was burst pacing.
Okay, so 260. So first peak side, second one blocked, right? Narrow complex.
Yes.
But the QRS is fusion. Second QRS complex diffusion. Do you agree
Yes.
or not? Yeah, that one. The minimum pre-excitation. So
It's frozen.
Oh, frozen. Can you show me the
CS1
Cut
is
AC.
this CS12 is the distal CS, right?
CS1 to, yeah, that's the most distal.
Yeah,
Why do you
always.
call it
In-
normal conduction?
in-
Then it's an eccentric conduction. Normal is 910 to 1.
No, normal V activation.
Yeah.
Far field V. Normally CS1 to its earliest end.
That is eccentric.
That's for the
What do you mean?
That's
What
for
do you
the left lateral wall.
No, it's for A that's eccentric. If CS1 to A.
If you're pacing A
If you're pacing A,
and down the node, the earliest activation is in the CS910, right?
yes. But for the V far field, the CS1 to is usually earlier.
Not earliest, but anyway, the earliest V far field was close to CS proximal, but separated.
Yeah.
Right? So not earliest. Can I see the
How can a pathway
Cut AC?
fatigue before AV node? Usually AV node fatigues before pathway.
Okay, let's see the left second bit. Can you explain why the ECG changed?
That's this one.
Yes. Look at the RB electron.
Yeah, there's
Okay.
Yeah.
a VPC
What happened?
fusion of VPC and this.
PVC, right? And during tachycardia, PVC, how
Resets.
changed?
Yeah.
How did it change the price and the sequence?
Also, possibly the actually after this,
Hmm.
this interval is also longer.
Delayed. It's a proof
So
of
possibly like it sort of resets it.
yeah.
Maybe it's the PVC sort of resets the tachycardia because it's part of the pathway.
But the Y choice was to change to even narrower. This is also during tachycardia, right?
Yes.
So I recommend to review that episode at 12 of the ECG and what changed it. That's interesting. Okay, so I think that Dr. Huang has some internet conduction issue. So anything else? Comment? Okay, so thank you very much, Kofi.
Thank you.
I'll give you the short lecture. Okay. 마이크가 안 되는데. 돼요? 이제?
교수님 마이크를 그냥 끄고
안 껐어, 아까. 껐어.
나는 중요한 게 진짜
음.
근데 지금 마이크가 이거 하나
주문 끊읍시다. 어쩔 수 없겠어. 예.
지금
Okay, can you hear me? Okay. 소리 꺼. 이 소리가 나면 이게. Okay. I'm sorry. We have so many technical problems today. So do I have to start from the first? Maybe not. But I cannot see the mouse. Okay. Okay. So Santangeli, actually in his paper, the multivariate analysis, GA is a risk factor for mortality. And given the 5% VT ablation related mortality rate in this sick patient group, this score is very useful. So I always check it before the procedure. However, because of this is a single center observation study conducted in Western country, so direct application of PANAS score to Asian patient has some limitation. In addition, the monitoring of cardiac power output, SVO2, lactate, and pH during VT ablation is essential to assess the risk during the procedure. In case of hemodynamically unstable VT or cardiogenic shock, hemodynamic support by ECMO or Impella is essential. However, post-procedure weaning of this hemodynamic support is also a critical issue. And Della Bella group recommended weaning when cardiac power output over 0.6 watt, lactate level less than 4. We experienced decompensate heart failure after VT ablation in 78 male patients with DCM and VT with multiple morphology. Okay, there are many morphology of VT. This is the usual pattern of DCM, the VT. As you expected, this patient has multiple patch scars and multiple VT foci. After scar homogenization by epi and endoablation, we confirmed non-inducibility and sought all very successful VT ablation. However, his heart failure was decompensated after 2 days in CCU. We eventually implanted LVAD after 3 months for this patient. After 5 years, he's still very happy and come to the outpatient clinic with LVAD. What about VT in patient with LVAD? This is VT episode 1 month after LVAD implantation because blue line is no VT, red line VT. Because of LVAD support hemodynamically, the presence of late VT or ICD shock did not affect the survival. But look at the survival. Survival outcome is quite poor even after LVAD, about 30% mortality within 2 years. Okay, now I would like to discuss the anesthesia issue. This study was done Stevenson group, compared the VT ablation under GA with IV conscious sedation in the single center non-randomized retrospective study and found no difference in VT survival. However, NIPS before and after VT ablation in general anesthesia group, only 28 out of 73 patients developed the same type of VT. In contrast, recent study found a significantly higher VT survival, VT recurrence rate with GA than IV conscious sedation. Selection bias, which favors GA in higher risk patients, may have played a role, but PANAS score also include GA as a risk factor for mortality. Therefore, I avoid GA whenever possible in this sick patient group. Okay, this is 55 years old male patient, DCM, referred due to recurrent ICD shock. We carefully conducted the endo and epi-substrate map on the GA. Unfortunately, however, we could not induce clinical VT at all. So we finished the case after substrate modification, ablation, and successful non-inducibility test, negative non-inducibility test. However, the patient came back to emergency room because of VT storm a few months after the procedure. This time we used IV sedation during the intubation status and successfully ablated by dechanneling procedure. patient is free from VT so far. And antiarrhythmic drug used after VT ablation also significantly impact VT ablation outcome. This study is a sub-study of a VANISH-2 trial. Everybody knows what is VANISH-2. This VANISH-2 sub-study compared the ablation versus antiarrhythmic drug after separating the amiodarone strata and sotalol strata. It showed that the significant superiority of VT ablation in sotalol group alone. In contrast, there was no difference in the outcome between ablation and amiodarone. However, amiodarone had a higher rate of long-term adverse events and non-cardiac deaths compared to VT ablation with a statistical significance. Okay, next, reality gap in risk marker concerns disease biology and progression. The non-ischemic VT category encompasses a variety of progressive conditions. As you know, the ejection fraction is established a risk factor for overall mortality and sudden cardiac death in patients with heart failure. However, as Meyerberg reported, the low ejection fraction account for less than half of sudden cardiac death event in this patient group. This means the pump failure deaths increased additional to arrhythmic deaths. This study compared the total mortality score with arrhythmic death score, showing the non-arrhythmic mortality increase exponentially with higher risk. So ejection fraction is an important factor for heart failure associated ventricular arrhythmia, but there is a significant limitation gap. The non-ischemic VT category encompasses a wide range of disease biology, as shown in these two studies. Recurrence rates after the non-ischemic VT ablation are significantly higher. Sarcoidosis, valvular heart failure, hypertrophic cardiomyopathy compared to other types of cardiomyopathy. And Zeppenfeld reported a late gadolinium enhancement pattern in MRI and non-ischemic cardiomyopathy group. Lyme cardiomyopathy has prominent septal involvement. Cardiac sarcoidosis predominantly involves epi or intramural basal septum. Myocarditis involves mid to basal posterolateral wall. Chaga involves epicardial basal posterolateral wall. This patient has Lyme and titin dual mutation cardiomyopathy, which shows so many different morphologies, 4, 5, 7. Okay. So he underwent 4 times of VT ablation procedures, and the substrate pattern and VT foci kept changing. Therefore, he eventually underwent cardiac transplantation successfully. You saw his explant heart specimen at the beginning of my presentation. Lastly, I will review the management guidelines based on diverse etiology of non-ischemic VT. Okay, first for hemodynamic stable ischemic VT, coronary artery disease, the mid-range heart failure, ejection fraction over 40%, ablation, ICD, or amiodarone, all accepted options. However, ICD backed up ischemic VT, amiodarone recommended first based on the VANISH-1 criteria. If VT persists after amiodarone, ablation is a class 1 indication. For the patient with mid-range heart failure and frequent PVC over 10%, ablation is recommended as a class 1 indication if cardiac MRI suggests PVC-induced cardiomyopathy. Okay, for the patient with DCM or hypertrophic non-dilated cardiomyopathy, you should consider genetic test in patient under 50 with family history or AV nodal conduction disease. If you confirm the Lyme cardiomyopathy with ejection fraction lower than 50%, non-sustained VT or AV conduction delay, ICD should be considered as class 2A indication. And in patients with mid-range EF who have 2 or more risk factor, ICD should be considered as class 2A indication in this patient group. And in patient with heart failure with mid-range EF, Okay, for VT, patient with VT associated with myotonic dystrophy, EPS should be considered if this patient group experienced syncope and documented AV block. ICD is indicated instead of pacemaker implantation. Okay, in patient with cardiac sarcoidosis, ICD should be considered as class 2A indication if pacing is required or a significant MRI LG is demonstrated. And for sustained ventricular arrhythmia associated with congenital heart disease, ICD or VT ablation should be chosen based on the biventricular function and hemodynamic tolerance. So this is my take-home message. VT has a variable prognosis depending on its etiology, and post-VT ablation non-inducibility tests suggest low VT recurrence, but 5-year VT-free survival remains less than 6%. And the PANES score is a useful VT ablation risk index, but requires validation in Asian people. And general anesthesia reduces the VT inducibility and is associated with higher risk of recurrence or mortality. Amiodarone exhibits an antiarrhythmic drug effect similar to those of a VT ablation, but is associated with significantly higher adverse events and mortality, non-arrhythmic mortality. Target lesion prognosis and management plans should be tailored to the diverse etiology of non-ischemic VT. Okay, thank you very much, and I'm happy to have your questions. Thank you.
Thank you for nice lecture, Professor Park. I'm Min Kim.
Hi, Dr. Kim.
Yeah. Can I ask a question?
Sure.
Yeah. Recently, not recently, from my experience, I have two patients, myotonic dystrophy with ventricular tachycardia. So I have implanted ICD in two patients. They are very young, but their muscle function, peripheral muscle function is very weak. Recently, a patient suffered from the ventricular tachycardia and ICD, appropriate ICD shock. So, do you have any experience in myotonic dystrophy VT procedure? And if you have an experience, is there any procedure tip or helpful advice?
Actually, I have a few patients with myotonic dystrophy who underwent AF ablation, but not VT ablation, unfortunately. But the most difficult one, this patient has some deformity and musculoskeletal problem, and the respiratory problem is also a very important issue. So I think the risk stratification and also the monitoring during the procedure, post-procedural the care is very, very important for this patient group. So I wonder, Dr. Huang, are you there? If you have a experience, could you please share your experience?
안 계신 것 같습니다.
So, any people? Dr.
No.
No. Myotonic dystrophy.
I have no experience.
Okay. But I think the most essential part is respiratory care. Yeah. They cannot expectoration easily. So I recommend to anesthesiology backup. If the patient condition is bad, you need to switch to general anesthesia in this high patient group.
Yes, thank you. Thank you, Professor.
Yes, please.
You mentioned that GA reduces inducibility and long term has a poorer prognosis. So, is there a way around it? Is there a way to improve? Because sometimes the GA is needed.
Yeah.
So, is there any evidence on how to improve the GA outcomes?
Actually, these studies are not the randomized clinical trial. there's a significant bias because we prefer GA rather than conscious sedation in very high risk group. So probably that is one of the reasons those patients shows a worse prognosis. But anyway, the inducibility test doesn't work well under the general anesthesia. That's the message of this two studies. Okay. Any other comments? Question? Okay, it is already almost 9 o'clock Saturday morning. Thank you very much for joining us. Have a wonderful weekend, everybody. Bye.
Thank you.